Dr. Winarwan, and thank you, Professor Fatemi, Dr. Gita, and Dr. Chakra for all excellent lectures. My first question to Professor Fatemi, if we see the number of receptor of FSH is decreasing toward the end of the proliferative phase, can we say step down is the better option? And is it any different in the different age of group? And then the second question about the premature progesterone rise. Is there anything we can do to help the quality of the eggs in that cycle, or we just lose the cycle? And my third question to Dr. Gita or Dr. Chakra, the composition of FSH and LH for the woman above the 75 years old, is there any different if we start from 75 or 150? And we know the LH is increasing the receptor. Can we start from 75? Is there any different? And Dr. Chakra, first example of, from your cases, first one, the 3 cycle before the 4th one, the egg number is only 3. And your cycle get 16 eggs, right? What's the difference? Thank you very much.
So many questions. You should know we are getting old and we start getting Alzheimer. You know, we forget most of these questions. So thank you for the questions. Your first question, you know, if you look back to nature, I always say we have to learn from nature. We cannot improve nature. We have to learn from nature. If you take a look at nature, what nature is doing, the FSH goes up, but the moment the follicle, the dominant follicle is recruited in nature, you have a monofollicular growth, you have one follicle growing. When this follicle is growing, what does it do? It produces estradiol, right? So when this follicle is growing, it produces estradiol. What does estradiol do? It suppresses FSH. So when a follicle reaches a size of 10 to 12 millimeters in nature, the FSH is going down, right? Now you would say FSH goes down, so the follicle goes to regression. No, that follicle continues growing. Why? Because it has less FSH receptors. That's an important point. So when you say, so would a correct stimulation be a step down? Absolutely, absolutely. The only problem is it's not one size fits all, because if you do your recruitment and you have a systemic FSH which is already low and is independent of what you have given, and that's a mistake ESHRE did. You know, ESHRE came out with guidelines last year. They said you have to give 300 maximum. Above 300 is not good. There you see this is coming from people who have limited clinical experience and who'd never measured the FSH. Because if you measure your FSH, you know, we have collected data of around 100 patients because we always measure FSH and we always measure on the same time. We have patients, you give them 300 of FSH, and after 6 days, you measure the systemic FSH. The systemic FSH is 8 or 9 with 300 of FSH. So with these patients, you have to go to maybe 600 to have a systemic FSH of 20 or 23. But you will have patients you give 150 and the systemic FSH is 20 because the clearance is different, right? So it's very simplistic to look just to the dose you give. It's not the dose that you give. Many studies compare 150 with 300. It's not the dose you give. It's like you say, I'm sitting in this car, I'm going to give full gas. How fast do I go? It depends if you're in a Ferrari or if you're in a Tata, with all the respect to the Tata, by the way. So it depends on what is the clearance, what you have. We know that you cover all the receptors with a systemic FSH of 23. This is beautiful work from Bob Casper from Canada. You see, if you have 22 to 23 systemic FSH, you capture all your receptors. If you have an FSH of 30 or 40, it's too much because there are no receptors for that. So first of all is how much FSH is absorbed, not how much you have given, how much is absorbed, what is the systemic FSH, what is the follicular dynamics, what is your basal FSH, And the moment your follicles reach a size of 13, 14 millimeters, then you know you have less FSH receptors. But the follicles need to be synchronized, because if you have 2 to 3 of 14, 15, and 7, 8 of 8 or 9 millimeters, you want to go for the smaller ones and rather than the big ones. So it's important also that you have a synchronized follicular cohort. And then indeed you need to go a step down. Now, the second part of the question is more challenging, because you said, is it for everyone, or is the difference between poor responder, normal, or high responder? And here I'm going to ask you a question before I answer that question. Or I'm going to ask the whole audience. If you have a poor responder, at what size follicle would you trigger that poor responder? 18? 16? 17? Anyone less? Any more so I can hit the hammer? 16, 17, 18, right? Good. So before I answer that question, a woman who is a poor responder, does she have a cycle of 28 days? No. Shorter, right? Why is it shorter? FSH is high. FSH is high. What happens if FSH is high? The follicle grows very fast. Good. But what does FSH do when it's high? It also creates LH receptors, right? Good. What happens if you have more LH receptors faster? Maturation is accelerated. So do you think that patient will ovulate at 18 millimeters? No. So these poor responders, the maturity is much faster. And I would highly recommend you to read a paper we published 1 month ago in a very high impact factor journal. For the first time, you need to think out of the box in order to change things. It is wrong to trigger a poor responder at 16, 17, or 18 millimeters. I'm talking about extreme poor responders. I'm not talking patients who have 7, 8 eggs. I'm talking with 1 or 2 follicles, or maximum 3 follicles. These patients have elevated FSH. They have faster recruitment of the follicles. They have more LH receptors. And the best time to trigger these patients is around 12 to 13 millimeters. You might say, this guy is crazy. I will never do that. I would highly recommend you to read this paper. So now when we say poor responders, these poor responders, it's even more important to reduce the pressure, because what you saw with the number of FSH and LH receptors is more prominent with these patients. So they will have faster their receptors. And there is a difference if you have a progesterone of 1.5 with a normal responder, with a high responder, or with a poor responder. Because the 1.5 diluted by 25 follicles, 1.5 diluted by 10 follicles, 1.5 diluted by 2 follicles makes a huge difference. Because per follicle, it's a big amount of progesterone, and it's not the total number which is important. It is how much per follicle is being produced, and I think that's a very important point. I think the second question was to you, if I remember well.
Okay, thank you so much, Dr. Aida. So I'm not sure that there is a certain doses for recommended LH here for supplementation for poor responder patient, but in my experience that we can start from 75. Yeah, so if you give 150 or 225 until 300, I guess 300. So the LH recommended LH is about 150, and beyond that, I prefer to combine with recommended FSH. Yeah, and what I observed that the follicle development is quite good, but I'm not sure other maybe Professor Fastemi have an experience beyond 300 or beyond 150 for recommended LH in patient with poor responder. Do you have any?
I fully agree on it. Yes, absolutely.
Yeah. For the dose for supplementations, for me, usually use the ratio in 2 to 1 ratio, and also it's more practical because sometimes we use 225 recommended FSH. It's very practical if we give 112.5, something like that, or we give the 300 IU facet, we give 150. And I think it's more practical and also can give the optimal result with the ratio 2:1 for experimentation. Oh yeah, for the third questions, yeah, I also surprised for these patients when the patients come to my clinic, because when I check all the parameters is good, but these patients is do the IFS, the 3 IFS is all a different clinic. So when I ask the patients that what I know that the patient never give LH in all the 3 previous cycles. So, oh, okay. So maybe I can give LH and hope can have difference. And fortunately, when I give this patient the LH and all became a difference. Thank you, Dr.
So the second question.
Thank you, Dr.
yeah.
Gunawan. Maybe my questions to Prof. Fatemi and Dr. Gita Pratama. Dr. Gita mentions that supplementations of LH in the beginning of the cycles actually give better result for poor responder. But can I just ask, how is the pathophysiology, as the small follicles normally do not develop LH receptors yet? And how can LH supplementations give additional benefit? Thank you.
Yeah, thank you for the question. You know, a follicle which is, let's say, 4 or 5 millimeters, it's not that it doesn't have any LH receptors at all. They have some LH receptors, but maybe 10%. It's really the minority. On the other side, again, it comes back to the point, it's not one size fits all. You see, some women, possibly those ones who have elevated FSH levels, they might express more LH receptors than others. And, you know, I think what we have published in the past, we have to rethink it. You see, today, let's say if I go to ESHRE in few weeks, which I don't, but if I would go there, I think more than 90% of the publications, I would say they are wrong. I'm sorry to tell you that, but this is the reality. Because most of us, we have a tunnel view. We look at one thing and neglect other things. But you need to get one step back to have a more holistic approach to understand, okay, is this what they have published correct, or are there anything or any factors which might interfere with that? So what you see, yes, most patients have maybe 10% LH receptors, but does it affect everyone? No. There will be other patients which might express more LH receptors. There will be others which will express less. Globally spoken, you're right. Globally spoken, a normal patient, most probably there will be no sense of giving LH because they will not have enough LH receptors. Will there patients who will have more receptors? Yes, of course, there would be. And this is the subgroup of patients which would benefit from that.
The second question?
I only have one question. Yeah. Thank you.
So regarding the study, all of the comparing the day 1 and day 6, they are coming with the fresh embryo transfer. Of course, the LH has an impact on the endometrial receptivity itself. It seems like it boosts the better receptivity. Do you think it will be a different if the put in the frozen embryo transfer, because in terms of maybe is any different of the quality of the embryos resulted from day 1 supplementation LH and day 6 supplementation?
It's a difficult topic. You know, this is research which initially Vangelis Papanikolaou, when he was in Belgium, was promoting. And specifically in China, they do a lot of work on LH and the receptivity and quality of eggs and so on. I am a little bit doubtful whether it is truly correct what they are publishing. Personally, we have stopped completely fresh cycles. We don't, I think it's unethical to do fresh cycles because we know the moment you create multifollicular recruitment, the endometrium is advanced. That's what it is. And if you have a good freezing protocol and you rely on your lab, I would completely stop transferring fresh. Now, you know, when we talk about shortcomings of publications, even publications, we agree human reproduction is a good journal. It's a good journal, right? Human reproduction. We all rely on the publications. About 1.5 years ago, maybe 2 years ago by now, there was a beautiful randomized controlled trial from the Netherlands. Okay? And it was a very straightforward study. It was randomization, fresh versus frozen. Beautifully conducted study. Less than 36 years of age, good responsive patients. And the conclusion was, it is wrong to do frozen embryo transfer. It's better to do fresh. It's the opposite what I'm telling you, okay? Now, if you read that paper, if I would ask you all, in a young population, if you freeze embryos, what would be your pregnancy rate? What would you tell me? If you freeze an embryo, let's say less than 35 years, what would be your pregnancy rate? 60%. Thank you. Do you know what was the pregnancy rate in that particular lab in the Netherlands? 6%. So the conclusion is freezing is bad, you should do fresh. Of course, in that lab, you should never freeze. But does it mean that it is the truth? Now, these guys, they will put it in the next meta-analysis and they will say, yeah, fresh is better than frozen. So this is this is a human reproduction paper. I would recommend you to read that. And I can give you hundreds of these publications. And the same is with the impact on LH. Yes, there are LH receptors. Fresh, I would never do that, never. There have been studies also from Egypt. Abul Ghar did studies where they added, I think, ACG or LH, and they improved the receptivity. But personally, I think the biggest factor for the receptivity is to understand the synchronization of embryo and endometrium. Because not every embryo is developing on the same pattern. And not every endometrium is developing on the same pattern. So today, through AI, we are currently working on a system how we can synchronize the embryo and the endometrium together. And last but not least, speaking on endometrium, if I would ask you all, what is the good thickness of endometrium? What would you say? 8, 9, 10?
7.
At least 7. I take the hammer again, more or less. Everyone agrees? 7? 8? He remains politically correct. He doesn't say anything now. So we published a paper in Fertility and Sterility about a year ago, 1,000 patients. We synchronized the embryo and endometrium. And we checked all the endocrine profile. We did single embryo transfer, genetically tested embryo. So all the variables were excluded. 1,000 patients. And you know what came out? Endometrial thickness does not matter. Between 4 millimeters and 13 millimeters, there was no difference. So this is why we have to rethink. At the end, we put too many variations into equation, and something comes out, and we jump on one variable, and we neglect the other variables. I think it's time to have, again, a more holistic approach. Yes, thickness might be important, but maybe it is important to check to the genetics of the embryo, division pattern, synchronization of embryo and endometrium. I think these factors are much more important than what we are currently looking at. By the way, for that paper, the fertility and sterility, Barisata is the first author, which we published last year.
Let's say it's 4 millimeters house.
Yeah, we excluded, for ethical reasons, we excluded that.
So the minimal
4 millimeters. So we went, and it's a beautiful graph. I can show it to you. I have it on my laptop. It's a beautiful graph. So you look to the pregnancy rates, and we stratified HRT cycles, natural cycles. We look to the endocrine profile, single embryo transfer. And you know, we have a statistical unit. I have no clue how they do that, but they make beautiful graphs. And you can see that there is no difference between 4, 6, 8, 10, 12. It goes like this. And there is no statistically significant difference. Why? Because there was no heterogeneity on embryos. There was no heterogeneity on the hours of progesterone exposure. There was no heterogeneity on synchronization of embryo and endometrium. Because not every embryo is developing on the same pattern. You could say, I have a blastocyst. Is it a day 5 blastocyst? Is it a day 6 blastocyst? How many hours after the injection? What was the division pattern? How many hours of progesterone exposure do you have? So all these things at the end matter.
Okay, thank you. So any else question from the floor? Yes,
Hi,
please.
thank you, Dr. Pinawan. My name is Andrew Chan. I'm from Orla. I'd like to thank Merck for inviting all the distinguished speakers for sharing their experience. So just a statement and then maybe a question. I totally agree that, every woman is different. We need to have personalized treatment for in IVF for women because women are different. Not only are women different, but they also differ from cycle to cycle in their own very much their own cycle. But my problem is this, that the tools that we have to monitor, what you are saying is very inaccurate. So you're talking about measuring bloods during the cycle. So, estrogen, FSH, whatever. We know that this varies depending on what time you measure. We know that it is dependent on the quality of the lab, and we know it differs from lab to lab. We depend on ultrasound measurements. And that is inter-operator dependent, where you put your axis, even your endometrium, a study like that, where you put your axis will determine whether it's, 5 millimeters or 6 millimeters. So these are the tools that we have to measure, to monitor. And what are the tools that we have to try and change within a cycle? Maybe you add a bit of LH, you decrease the dose of FSH. And do you think that by doing that, adding a bit of FSH, increasing your dose, decreasing your dose, adding a bit of LH will actually change that? So my statement, I don't need an answer, is that yes, personalized treatment in IVF is the gold standard, but we are not there yet. We're not there yet because we don't have the tools to personalize the IVF. So my question, I've got two questions, one to you and one to Dr. Chakra. The question is, this progesterone rise, which decreases the quality of the eggs, okay, is a little bit different from what I'm used to because we all know it affects the endometrium. But in all studies, including some of the studies that we did in IVF Australia, where we looked at whether there's this concept of one and done. You just hyperstimulate, wow stimulation, you get as many eggs as possible. And we were trying to prove that, more eggs affect the quality of the embryos. We look at the euploidy rate, we look at the pregnancy rate, and not only our study, but lots of studies have not been able to show that more eggs is actually worse. I know, we're not talking about OHSS, risk of torsion and all that, but in terms of actual live birth rates, cumulative, in terms of euploidy rate, we have never shown that more eggs, which should be your case if you're going to increase the progesterones and have better, worse quality eggs. So that's my question. How does it correlate? My question to Dr. Chakra is, how do you, in all your patients that you were looking at, and you said that some of the patients you added LH, is there a way that you can determine which these patients are before you start the stimulation, rather than do 1 or 2 cycles and then find out, yes, we need LH? Thank you very much.
So thank you for the questions. I fully agree with you that there is an intercycle variation. The first who published that is George Griesinger, where they described that you have 27% intercycle variation between the cycles. Absolutely. Now, regarding relying on the lab, this is the base of my full presentation. You need to have a lab on which you rely on. I don't visit our blood lab, but when they see me in my blood lab, they all have epileptic seizures because they know I'm going to shout at them that I'm not happy with the results that they have provided us. So you have to rely on your lab. This is extremely important. That you have variation of progesterone, we published a paper with UPMA, I think 3-4 years ago. Yes, you do have this variation morning, noon, afternoon, but not on the day of ovulation. And when we do a frozen cycle, for example, in a natural cycle, what is happening, it's beautiful. And we have published many papers. You should read these papers. Barbara Lawrence is the first author of most of these papers, where describe the pattern on our basis, what progesterone, what LH is doing. So what you see, the change of endocrine profile in a stimulated cycle as compared to a natural cycle, they differ. The stimulated cycle, your progesterone is the highest in the morning if you give your FSH in the evening. Why? Because when you give FSH in the evening, you reach your peak in the morning within 12 hours. And this is the time where your progesterone is the maximum. And when you wait during the day, progesterone goes up because the pressure of FSH gets less. So that has all been in detail published. There is a publication from Denmark, Leif Bungum is the first author. There is a publication from us, UPMA is the first author. There is a publication by Nikos Polizos, Human Reproduction, but they did it differently. They describe morning and evening, and they say there is day and night rhythm, but they neglect the time of FSH, which has a little bit of shortcomings. Now, regarding the stimulation and dose adjustments, so you need to fully focus on the lab that you do and the time you have administered your FSH. Now, regarding the papers that you have published, I am aware of those papers, but those papers have one significant shortcoming. And if I would have reviewed them, I would have rejected them, by the way. And I will tell you why. If you would have listened deeply into the presentation, you have seen it's not one size fits all. You see, when you say high responder, low responder, more eggs, less eggs, at the end, it is how the stimulation is done. What is your systemic FSH on the day of final oocyte maturation? You might give 200 units of FSH. You might have a systemic FSH of 7, which is very low. You might have a systemic FSH of 27, which is very high. And this was the paper I was elaborating on. Now imagine you have a patient whose clearance is slowed down and you have pushed her too much and you have high levels of FSH, because those studies you're referring at, not a single one of them measured the systemic FSH, not a single one of them. So if you would have the systemic FSH and stratify based on systemic FSH, progesterone per follicle, size of the follicle, you would have seen that those patients who receive too much of FSH, they would have the worst results. But if those patients would have been individualized, would have been unstimulated correctly, you would have enhanced the quality of the oocytes, you would have less aneuploid embryos, and you would have higher cumulative pregnancy rates, as it has been published also recently by Mentoni Fertility Sterility. So it's not high responder, low responder. It is how was the stimulation done? It's the same. You have a Ferrari, you crash it, and you say, okay, it's not a good car. No, it is how was this car driven? How was it controlled? It's called controlled ovarian hyperstimulation. And I know in Australia, there is very little measurement of endocrine profile. They started a few years ago measuring estradiol and progesterone, but no one was measuring the systemic FSH. But the FSH is the engine of growth. And if you don't know how much systemic FSH you have, you might create more aneuploidy. So this is why, yes, I stand to the point, more eggs better, of course, not 50 or 60, but the more eggs that you have on a controlled way, controlling the endocrine profile, controlling the systemic FSH, controlling the progesterone per follicle, that will have an impact on the quality of oocytes, as published on many occasions.
Thank you. So the question for the Dr.
Thank you,
Chandra.
Dr. Gunawan. Yeah, it's very, very interesting questions. That of course we don't know how to determine which patients that we should give the LH from the beginning. Maybe some papers said that maybe it's clear for patient in advanced maternal age, but for young patients before 35 years old and the first cycle IVF, sometimes we have any doubt that the patient is really need the LH or not. But to check the polymorphism or monitoring the LH, I think is not really practical for our daily practice. So, but I have some study. I have read some study by Cole. They check the LH level 24 hours after the antagonist, and if the LH level is suppressed or oversuppression after 50% after 24 hours of antagonist is the indication to give the LH. But sometimes we don't know that in 24 hours it's still not oversuppression, but could be tomorrow there will be oversuppressions. So I think, yeah, it's still challenging to which patient to select which patients in young patient that we should give the LH. But from my experience, that giving LH is not harmful. So I have a lot experience using the LH for normal responder patients and with a good result. And yeah, it's also could be interesting that should if we really aware uh, to have the hypo respond patients, we can use the LS in every patients or initial evaluation monitoring the follicle development at least at 4 days, 3 days after first stimulation and rescue the follicle is the best choice, I think.
Thank you. So is there any question from the online question?
Yeah. One more.
Okay, so let us give a chance for online audience to give their question. The first one, I think, is to Prof. Patami. So that is the question. The slide show that the more oocyte, the more pregnancy. But the other slide said the more high level of FSH can make more unemployed embryo. Can you explain?
Yeah, that's what I mentioned previously. You see, it's FSH, you create multifollicular recruitment. But if you don't do the step down towards the end of the follicular phase, you might jeopardize the quality of the eggs. So you can stimulate in the beginning to have multifollicular recruitment, have a good number of eggs. But if you continue with the FSH and you push too much towards the end, you jeopardize the quality. So the aim is to have a multifollicular recruitment and towards the end to do the step down and measure your FSH, estradiol, and progesterone per follicle in order to have the best quality of the oocytes.
Thank you. So because of the time constraint, maybe we have one of two questions to Dr. Gita. How about the latest evidence of coenzyme Q?
Okay, yes. I haven't checked what the meta-analysis last or recent meta-analysis for coenzyme Q10 for proliferative reserve, but yeah, the base of this because we found that the mitochondria, especially for the patient with older women, like more than 35 years old, I guess, is decreasing. And I think what that people try to do is to provide more to increase the quality of the oocyte, but I don't have any recent studies or meta-analysis about Q10.
Thank you, Dr. Gita. Dr. Chakra, any benefit to give more than 300 IU FSH in poor ovarian responder?
Yeah, I think, yeah, I agree. To start more than 300 IU, I don't think it's really needed in most of the patients. But maybe for some patients could be have benefit. Yeah, but for starting, I don't think that I will start more than 300 if no history before. But sometimes if the patients have, I already give 300 and the follicle is not growing, something I just cancel and you know that every cycle could be vary and I start again 300 IU and the follicle is growing, sometimes like that. But maybe for the patient with the polymorphism of the FSR receptor, maybe we need more higher FSH.
Thank you. Is there any short questions from the audience? Short question, please.
Yeah, sure, just short question. Regarding the window of implantation for a case of displaced window of implantation or recurrent implantation failure, can you assure that the simulation cycle when we are doing the endometrial receptivity analysis can guarantee that the next cycle the window of implantation will be on the same time, or it can be displaced as well in a HRT cycle patient? Thank you.
Yeah, thank you for the question. So you are referring to recurrent implantation failure and to the receptivity test of the endometrium. So these are two different things. So first of all, regarding the ERA test, the endometrial receptivity assessment, the people who brought up this test One of them was Nicolas Garrido. They published a paper a year and a half, 2 years ago, that you should not do the ERA test. So this test is not reliable. And you should not conduct the genetic testing of the endometrium because simply it's not reliable and it's not replicable and it's not recommended to do so. So I think that test we should refrain of doing. This is number one. Now, when you speak about recurrent implantation failure, we published a paper, I think 6 weeks ago in Human Reproduction. It's a multi-group assessment with many clinics around the world, several hundred thousands. If I would ask you, what is the prevalence of recurrent implantation failure? If you put back a correctly analyzed, genetically tested embryo in an endometrium where you respected the hours of progesterone exposure, and you put back 3 subsequent genetically tested embryos, what is the RIF, recurrent implantation failure? 2%. So if you test the embryo and you put it back after the hours of progesterone exposure, the recurrent implantation failure is less than 2%. So it's neglectable. And most probably these 2% could be because of immunological reasons, because of progesterone receptor resistance and so on. But I think common things are common. Most reasons of implantation failure is a genetically abnormal embryo. If you have respected the hours of progesterone exposure. We had a patient, I never forget that patient, when I'm talking about 7, 8 years ago, the times where there was this hype on ERA. And I was never convinced by that. The patient came from Switzerland to me in Abu Dhabi. She said, I did my ERA test and I want you to follow up the ERA. But I said, but with the ERA in Switzerland, you didn't get pregnant. Why you want to repeat the same thing again? She said, no, they said ERA is good. And I said, okay, let's do one deal. I'm going to do your ERA and I'm going to see if it's replicable, because this is your question, if ERA is replicable. So what I did, I blinded the genetic lab. iGenomics was a genetic lab doing it at that time. So every time we send it under a different name of a patient. So they did not know it's the same patient. In their publications, it's replicable. Because if it's out of phase now, it should be out of phase next month, in 3 months, and in 6 months. So we send this sample 4 times, and guess what? We have 4 different results. Pre-receptive, post-receptive, I don't know, so many hours. I even think we published that case. I think it was a case report that we published 6, 7 years ago. So to tell you, no, we don't do the ERA test. I don't believe in ERA test. I don't think it's replicable. I think one of the main reasons of recurrent implantation failure is the genetics of the embryo and neglecting the hours of progesterone exposure. I think that's very important.
Okay, thank you. Due to the time is up, so I would like to wrap up the all the topics that Professor Human have Patami have mentioned, that progesterone rise will be like depending on those total doses of gonadotropin and size and the number of the follicles, and also it has a negative impact not only to endometrium but it's also to the oocyte. So one of the methods to prevent the rise is that we can do the individualized ovarian simulation. By one of the steps is by step downs. So also the most important thing is durations of exposure to progesterone to the times of we do the embryo transfer. And one of other interesting things is that measuring the FSH to see is there any difference in eliminations, so we can calculating the better dosage of the gonadotropin given to the patients. From Dr. Gita, that's have mentioned there's 2 way of as a adjuvant therapy for the responder. One is the transdermal testosterone. The other is LH supplementation for the responder patients might have a good opportunity to boost the successful rate in a poor responder patient. And from Dr. Chakra, giving LH supplementation early in the day day 1 or day 2 will not have any harms, but it might be helping some those subtype of patient which is categorized as hyporesponder patients. I think this all for the session 1. I would like to thanks Prof. Human Fatemi for giving a very excellent lectures, Dr. Gita Pratama as well, and Dr. Chakra for the giving very good exposure of the experience. Thank you very much.
Thank you. Thank you, Dr. Binarwan, Prof. Human Fatemi, Dr. Gita Pratama, and Dr. Airul Chakra.